And so, anyway, so it's really a cool little site. And sometimes I will send my, they also have CME and things like that. So, pretty cool little, pretty cool site. But it's on Radiopedia. It's RADIOPAEDIA. So it's like this Australian sort of spelling on Radiopedia. But I love Radiopedia. So that's another, if you get nerded out by any of these things, that's another sort of resource that you can do that really, you're not gonna get any, well, you can get CE. I just don't know which courses there are. But they do have them there. Okay, all right. So let's talk about CT, MRI, and then we are gonna, I think we are gonna call it a day. Okay. We got more to do tomorrow. Okay. CT was really, I mean, it's really developed in my lifetime, and I consider myself a fairly young person, so I feel like I've seen a lot of things in my lifetime. Do y'all know Nate Bargatze? Have y'all seen him on Netflix? So I went to see him in Little Rock, and he's hysterical, like 2 weeks ago. He's hysterical. And he talks about, you know, all the changes that have come in his daughter's life, and he says, you know, I have more in common with a pilgrim than I do my daughter, just because of all the technology, and I sort of feel the same way. But anyway, Sir Godfrey Hounsfield, and you'll see that word in just a moment. He looked at a group of X-rays and thought, can we combine them in such a way that we can produce a real image of a body tissue, right? And so he used a computer, that's why it's called computed, to produce the first computerized axial tomographic unit. Okay, so that's where we get the CAT scan, is exactly that. Now we've shortened that to CT, but it wasn't until the late 70s that we had CTs available. We didn't have them available before. And so how do we do all of, you know, the vascular things we did? They went to angiography. I mean, they went to angio. That was the gold standard for lesions. That was the gold standard for all of this stuff before we have all this non-invasive imaging. The axial slices are like this. Like if you chopped off my head, you'd be doing axial slices, okay? And so there's different configurations of all of that. But all of the axial slices, those are source images right there because they're all axial. And then you can use the computer and you can make a whole brain, right? So now I can do coronal images, which is the confront, which is this, slicing like this. Or I can do sagittal images, which is slicing like this on the side, so that you can see pituitaries really well that way. But again, CT developing in my lifetime, so pretty good. Now, X-rays are absorbed at different degrees by different tissues, okay? So this will be important for you to know. X-ray has no X-ray absorption, 0. Bone soaks it up, okay? And then everything else is in between, air and bone, everything else, okay? CT has, can distinguish between different types of soft tissues because there are different sort of grayscapes in the different tissues and how it absorbs those X-rays. So you can have a real qualitative evaluation of the soft tissue, of the differences in that, and you can also measure it. So for example, if you have a patient that had a CT and a CTA, that dye is hanging around there, and then for whatever reason they have another CT, and you don't know if that's dye or hemorrhage, you can measure that. Now, usually dye will go away, right? Hemorrhage doesn't go away in 24 hours, but you can measure it using Hounsfield units. That's where we get the Hounsfield units from, is measuring that absorption difference. Okay, so here it is, right here. All right, air is on CT is black. And you get everything in between, and then you get the hyperdense bone. This will be an important one for you, okay? Bone soaks it up. Air, not so much. So that's why when the acute hemorrhage and radiographic contrast comes up as bright, it's because it's absorbing it, okay? Sometimes you can't tell the difference between the two. So that's why you need to measure that with Hounsfield units, and you can do that. The radiologist can do that. That's why they say it on their report. This is, so many Hounsfield units, which is likely blood over contrast. That's why they say stuff like that in their reports. Okay, CT is fast. It's almost universally available. It's much less expensive than MRI or any other imaging modality for that matter. There's really no contraindications for CT. All you have to do is have a patient that can lay flat. Now, sometimes that's contraindication because sometimes our patients won't lay flat very well. We can get around that. It has a high sensitivity for detection of hemorrhage, 100% on intracerebral hemorrhage, and 90% on subarachnoid. And so high sensitivity. And sensitivity means if it's present, it's there. That's what sensitivity means. Specificity means if it's not there, it's not there, okay? You can also on CT, because the bone soaks up all those x-rays, you can get really good display of your bony architecture and trauma. So all of these little, facial fractures and all that kind of stuff, you can really see it really well. What I will tell you is that the disadvantage in CT concerns the posterior fossa of the brain. What do I mean by that? Cerebellum. Posterior fossa is back here. Because that CT, the X-ray has to go through all that bone to see the soft tissue. You can get streak artifacts, and that's the reason why sometimes when you look at CT, especially on the in the cerebellum, you can see little streaks in it. So you don't get great resolution in the cerebellum or in the posterior fossa of the brain. And so those patients have to have MRI. I mean, there's no way to get around it if you're iffy on a pathology there, okay? The other thing too is CT does not recognize infarct in hyperacute ischemic stroke patients. They can be laying there plegic on one side and giving you all the symptoms of a large vessel occlusion, but that CT will be negative because it hasn't really processed the changes. Because remember, you have a little reserve, but you don't have a whole lot. So in hyperacute ischemic stroke patients, the CT will be negative. And I have to tell people that. I was like, you want it to be negative if they're in a window for thrombolytics so that you can give the treatment that you need to give. Okay, non-contrast are also always performed before contrast studies, okay? Because after you put in contrast, now you've obscured any visualization of hemorrhage.